We begin with the preparation of Klein solution, which provides local anesthesia, induces temporary vasoconstriction to reduce bleeding, and creates the tumescence required for liposuction. A small incision, approximately 10 centimeters lateral to the umbilicus, is made to facilitate cannular access. According to the patient's needs and comorbidities, the solution is prepared with 20 milliliters of lidocaine 2%, 0.5 milliliters of adrenaline 1 milligram per milliliter, and 250 milliliters of saline solution. Approximately 150 to 200 milliliters of Klein solution are infiltrated. To obtain more than 60 milliliters of lipoaspirate, a larger volume is required, maintaining a 3:1 infiltrate to lipoaspirate ratio. The solution is drawn into a 60 milliliter syringe and connected to a 16-gauge infiltration cannula. The cannula is introduced into the abdominal subcutis through a small incision, and infiltration is performed with fan-shaped movements, avoiding transverse trajectories. One hand is placed on the abdomen to control the cannula's advancement parallel to the skin. After infiltration, a waiting time of 7 to 8 minutes is required before proceeding to aspiration. Next, the LIPO-STEM DUO device is prepared. A 1-liter saline bag is suspended and connected to the 𝘱𝘰𝘧𝘦𝘐 valve. The clamp is opened to fill the device while the waistline remains closed. The device is kept vertical to ensure complete elimination of air. The lipoaspiration cannula, 13-gauge, is then connected to a 60 milliliter Vaclock syringe. The cannula is introduced into the subcutis. Negative pressure is created by locking the Vaclock plunger, and aspiration is carried out in the previously infiltrated areas using fan-shaped movements while avoiding transverse ones. Once the target volume of lipoaspirate has been achieved, the cannula is withdrawn and the incision sutured if necessary. For volumes exceeding 60 milliliters, a bilateral approach is recommended. The harvested adipose tissue is introduced into the LIPO-STEM DUO device through the 𝘠𝘮𝘰 valve. Using the provided spatula, the tissue is gently microfragmented over the filters, facilitating thorough washing and the elimination of oily, bloody, and pro-inflammatory residues from the Klein solution. The procedure continues until the tissue acquires a pale yellow appearance and the waistline flushes clear fluid. At this point, the 𝘱𝘰𝘧𝘦 clamp is closed, excess saline is removed, and the processed tissue is collected through the lipo-out valve into a 10 milliliter syringe. The resulting product is an autologous adipose fluid tissue ready for infiltration. The treatment area is disinfected. Ultrasound guidance is then used to verify the intra-articular target and plan the optimal infiltration trajectory into the osteoarthritic knee. If the material is too dense for easy injection, 2 syringes may be connected using an FL connector, and the tissue further fragmented by alternate transfers. If required, the syringes may be capped and placed upright to allow decantation before use. Finally, the infiltration tip is attached, and the processed adipose tissue is injected directly into the joint.